Coming to the most important point, that is OHSS. It is an iatrogenic condition. It will not happen on its own. It is created by the doctors who are treating the patient. Depends upon the number of follicles, not the size. Very important. Very, very important. It is depending upon the number of follicles and not the size of follicles. Okay. So you have to monitor as to how many follicles are there and what is the estrogen content. These are the indications to tell us that, okay, she is a high risk candidate for OHSS. Okay. Not size, it is the number. Not seen with letrozole. Okay. Triggering factor for OHSS is HCG. Remember this. So we don't give HCG when we are suspecting OHSS. Okay. We resort to a GnRH agonist, or we don't give anything. Just let the cycle get cancelled. So CC, that is clomiphene citrate, can give less than 1% chance of OHSS, but HMG have a almost 5% chance of OHSS. With letrozole, there is no OHSS, right? Not seen with letrozole. Now, what are the factors? Age less than 35 is a risk factor. Why? Because these women less than 35 will have increased antral follicular count. The number of follicles, as I told you, there is a programmed apoptosis going on in the females. Every month around 1000 follicles are dying. But if she is less than 35, she is young, the number of follicles will be more. So if the number is more, I told you number is directly proportional to the risk of OHSS. So yes, they are high risk. PCOS patients, because they have multiple follicles. Thin patients are more prone to have OHSS. Previous history of OHSS, anything in obs and gynae, anything in medical science, if they have a history, it tends to repeat. Estrogen more than 2500 picogram per ml, that is a high risk factor. Okay, we will come to this management. Normally, estrogen produced per follicle. Per follicle, how much estrogen is produced? It is 150 to 200 picogram per ml. Okay, so this is the amount of estrogen produced by per follicle. And if the estrogen is above 3500, so above 2500 is a high risk factor. If it is above 3500, there is a 1.5% chance, and if it is above 6000, then it is 40% chance. Okay, so at 2500 itself, the bell is ringing now. It should ring a bell in your brain that, okay, this is a high risk case. If it is more than 3500, 1.5% chance. More than 6000, then there is a 40% chance. Very, very risky. Okay. Now, AMH, if it is more than 3.3, that means the antral follicular count is more, but up to 5, we consider AMH as normal. But yes, if the patient is getting ovulation induction, you have to be careful as to what is the AMH, and if she is a PCOD patient, what is the estrogen level, right? Follicles more than 13, increased antral follicular count. HCG trigger has been given for pregnancy support. She is already pregnant and you are giving her HCG for the luteal phase defect. So if there is a luteal phase defect, what do we give? To the patients with LPD who have a tendency of miscarriage, we give HCG along with progesterone, right? So give these two things. So if she is getting HCG, then she will be a high risk for OHSS. And if she is already pregnant, in pregnancy already the HCG is going to go high. Already the HCG will be going to go high. So in case of high HCG, there will be a chance of developing OHSS in pregnancy itself. She is pregnant and now she is developing OHSS because there are so many follicles which are there inside the ovary because of the treatment, ovulation induction. Even though she is pregnant, she is now having OHSS because of increased HCG. Alright. So don't let her get pregnant if there is a risk factor. Estrogen going high, too many follicles, cancel that cycle. Otherwise, pregnancy is going to be difficult. Right? What is the pathophysiology of OHSS? Why are we talking about ovarian hyperstimulation syndrome again and again? Due to excessive FSH, because there is an estrogen deficiency because of the ovulation drugs, which is stimulating the FSH from the pituitary. Excessive FSH will cause hyperstimulation and excessive follicles, and now estrogen will increase. So it is causing hyperovulation. These follicles which are forming are secreting estrogen. I told you 150 to 200 picogram per ml per follicle is getting secreted. Now, this estrogen is going to increase the level of inflammatory cytokines. What happens in dysmenorrhea? What happens during menstruation? The local production of all these inflammatory cytokines from the endometrium is increasing. Similarly, when the estrogen is going high, the interleukins and the vascular endothelial growth factor, that is VEGF, it is basically going to cause leaky capillaries. Okay, so it causes the capillaries to go leaky. The leaky capillaries are now going to give ascites, that is fluid in the abdomen, hydrothorax, that means there might be pleural effusion and there might be collection of fluid in the chest, right? So that is very dangerous and it can be life threatening if it is not monitored and not treated properly. In the leaking of the capillaries, what is leaking? Fluid is leaking, protein is leaking and electrolytes are leaking. So basically the capillaries are losing their protein, their fluid and electrolytes, and it is coming in the extravascular compartment. So when it is coming into the extravascular compartment, then it becomes ascites, hydrothorax or pleural effusion. So that is the main complaint that the patient comes with, okay. And plus other pathophysiology will be, there will be hypercoagulability because of increased estrogen, chances of DIC will be there. Estrogen itself will cause hypercoagulability, plus because the capillaries are now losing the fluid, they are becoming highly viscous. The fluid inside, the blood inside them is highly viscous. So again, there will be hypercoagulability. Plus there will be now decreased urine output because the extravascular compartment is having more fluid. The blood flow to the kidney is reducing, hypovolemia leading to renal failure. So that is the pathophysiology. I am sure you know the pathophysiology much better than me because you are reading it in pathology also. This is all the kind of inflammatory pathophysiology of mostly all the inflammatory markers, right? Now coming to the stages, how we actually grade them. How do you grade OHSS? Grade 1, grade 2 and grade 3. Grade 1 is abdominal distension with pain. Now because distension is there, so there may be pain, but it is plus minus. So grade 1 is nothing. You have felt that there is a distension, patient is not complaining anything. In grade 2, there is abdominal distension just like grade 1, plus the patient is coming to you with nausea, vomiting and diarrhea, and the ovarian size that you have measured is above 5 centimeters up to 12 centimeter. The normal size of the ovary, we know the volume is about the size is about 5 centimeter. So now the ovary is enlarged, there is distension plus nausea, vomiting. Grade 3 is, now you can see ascites on ultrasound. So up to grade 1, grade 2 is fine. Grade 3 is now showing you that there is leaky capillary which is causing ascites. Grade 4 is showing you clinical evidence of ascites because now the patient is having problem. You had detected in grade 3, you saw ascites in sonography, but now the patient is complaining that she has distension. Then she may have hydrothorax or difficulty breathing because of pleural effusion. Okay, so these are the clinical evidences of leaky capillaries. And grade 5 is ominous. Grade 4 with evidence of hemoconcentration, coagulation, DIC and decreased renal perfusion, that is bad. Okay, so grade 4 and grade 5 are bad. Grade 1 and grade 2 can be easily, you can just tell her, you don't have to cancel the cycle, you don't have to admit her also, but you just have to be more vigilant. Grade 3 will be in between grade 4 and grade 2. Okay. Now, what can be the complications? Yes, it can undergo torsion because it's a heavy ovary. It's a heavy ovary like this. It is having lot of follicles. It becomes so heavy that it can undergo torsion. It can undergo rupture and it can undergo hemorrhage. So all the complications of ovarian cyst which can happen, it can rupture, it can undergo torsion, it can cause, it can undergo intracystic bleeding, that is hemorrhage, and we will discuss this in the chapter on ovarian cyst. Okay. Now, how will you prevent OHSS? First of all, you have to monitor the E2 levels. It should not be above 2500. You have to cancel the cycle or you withhold HCG if it is more than 2500. But the normal E2 levels should be between 450 to 1000 picogram per ml. Okay, you don't let them go beyond 2500. Normal, ideally, it should be between 450 to 1000 picogram per ml. Then you monitor the number of follicles, not the size but the number of follicles. So if it is more, it is 1 to 2 and they are more than 16 millimeter in size, you can withhold HCG if follicles are more than 13 in number. So this is ideal. Ideal is 1 to 2 follicles which are more than 16 millimeter in size, that is okay, but you have to withhold HCG if the follicles are more than or equal to 13 in number, right? Ovarian hyperstimulation syndrome, when the ET is 8 millimeter, you have to delay HCG if there are too many follicles and you have to decrease HCG dose from 10,000 to 5,000. I told you the ideal dose that we use in HCG is 10,000. Some companies are coming up with 7,500 because they think that OHSS can be triggered with high dose and 5,000 will be very low. So sometimes they do come with 7,500 which was available in some companies, but generally it is either 10 or 5. So we withhold, either we don't give, we delay HCG, we wait for the symptoms to subside, or we decrease the dose from 10,000 to 5,000, right? How will you prevent OHSS? So you have seen the follicles, you are monitoring the follicles more than 13, you either delay or you reduce the dose or you cancel the cycle. More than 2,500 estrogen, you cancel the cycle. Or you give leuprolide instead of HCG. You are either delaying HCG, you are reducing the dose, or it is better to give leuprolide, that is a GnRH agonist, instead of HCG, and the dose will be 0.5 milligram to 1 milligram subcutaneously for triggering the ovulation. or you can cancel the cycle in grade 3, 4 and 5. So 1 and 2 can be tolerated, you just have to monitor, don't admit. 3, 4 and 5, now she is having proper ascites, now she is having symptoms of DIC, renal perfusion is problematic, so now you have to admit her so that it is life saving for her and you have to cancel the cycle. Don't give even GnRH, right? Now, what else can you do? You can give cabergoline, because cabergoline, when it is given with HCG as a prophylactic, can decrease VEGF. So that is just something that can be used by the IVF specialist, especially if it is a very precious cycle. She's already struggling, she wants to get pregnant, they have spent so much on everything, they can't cancel the cycle. So what we can do is with HCG, if it is not yet in the grade 3, it is still grade 1, grade 2, reduce the dose of HCG or delay it, and along with that you add cabergoline. Okay, so that is going to reduce VEGF. Plus you can cancel the embryo transfer if it is possible. Cancel the transfer, just let the embryos develop there outside in the lab. After 3 to 4 days, when they are ready for transfer, you freeze them, and this freezing is also known as vitrification. They might ask you this, vitrification, although it's a very technical term for IVF specialists, but because they can ask you anything in exams, so just know the name. Vitrification means you are freezing the embryos for next cycle, because this cycle she is developing OHSS because of the HMG injections. So in the next cycle you don't need to give her HMG. She has already ovulated, you already have a fertilized zygote embryo sitting in the fridge, so you just need to transplant it. Then you use progesterone for LPD rather than HCG. So I told you that in the high risk factors, if you are using HCG to basically support the luteal phase defect, or you're giving HCG for pregnancy support, then stop HCG, just give her progesterone, that should be enough. Okay. How do you manage mild OHSS? That is something 1 and 2. That means there is no ascites as such, there is just a little bit distension and the ovaries are getting bigger, and the only symptom she has is mild pain and nausea, vomiting. In that case, just go for conservative management. Avoid strenuous exercises and intercourse. What is it going to do? Any uterine contraction or any increase in intra-abdominal pressure. Increase in intra-abdominal pressure can lead to ovarian rupture. Right? We don't want that. So avoid intercourse and avoid strenuous exercise. Plus, if intercourse can lead to pregnancy, that will also exacerbate the symptoms. If she gets pregnant, then the HCG is going to get secreted from the corpus luteum and later placenta, and that is going to exacerbate the symptoms. So in grade 1 and grade 2, avoid intercourse. You can just tell her that let's postpone the cycle or postpone the timing of your intercourse, so that you can maybe conceive later, because we have the follicles there. Then take analgesics because she's having pain, and consume a lot of fluids because there is a dehydration. There is a intravascular dehydration which is happening, which we don't want. Otherwise, it will increase the hypercoagulability, right? So let her consume more fluids. In moderate and severe, that is grade 3, grade 4, grade 5, admit the patient, especially if she has conceived. It is very important to admit her. If she has conceived, then the HCG is going to go very high. So please admit her. First line treatment will be to correct the electrolyte imbalance, because electrolytes are coming out of the intravascular compartment, coming into the extravascular compartment. Correct the hypovolemia by giving her IV fluids, which are either isotonic like ringer lactate, sodium chloride, or simply colloids. Or in case of tense ascites, you can do the paracentesis. Means in the abdomen you are putting the needle, you're going through the needle inside, and it is very easy to actually aspirate the ascites. You don't generally need a sonography, because you can just do a percussion. You can feel the dull percussion. It is normally in the flanks. When the patient is lying down, the ascites goes towards the flanks. So you can easily do a paracentesis. You can use a small needle so that you don't go very deep and injure the intestine. Just go in and connect it with a pipe and let it come down with gravity. So that is paracentesis, and we used to do this very often when we were doing PG. Prophylactic heparin to reduce thromboembolism. So initially with HCG, either you reduce the dose, you delayed it, or you added cabergoline, or instead of HCG you gave her GnRH agonist, or you simply just cancel the cycle. Now in grade, the moderate to severe grade, grade 3, grade 4, grade 5, now you are admitting her, you are correcting hypovolemia, you are correcting the electrolyte imbalance, you are correcting the tense ascites by doing a paracentesis, and you are giving heparin to prevent thromboembolism, because she is a high risk for DIC. Early OHSS, now there is a terminology called early and late OHSS. What does it mean? Early OHSS means it has happened within 9 days. So that was because of the triggering of the exogenous HCG injection that you gave. So if you gave her HCG injection and she landed up in OHSS, within 9 days it should happen. If it is happening within 9 days, it was your iatrogenic HCG injection. But if it is happening after 9 days, it was not because of the HCG trigger, it was because of the endogenous HCG, because probably now she is pregnant. Okay. So when it is coming after 9 days, it was not because of the injection. It should happen within 9 days. If it is happening later, that means she's got pregnant. She has a source of HCG coming in. Something else is secreting HCG, and that is the pregnancy corpus luteum. Okay. Remember, whenever there is untreated hypovolemia, why do we have to treat hypovolemia? The untreated hypovolemia, what is it going to do? It is going to dehydrate the capillaries, increase the chances of DIC. It is going to decrease the renal perfusion and may lead to renal failure. And it may also lead to liver dysfunction, hepatic dysfunction, because all these organs are not getting proper blood supply. So the hypovolemia is very important to be treated, and you have to tell her to drink a lot of fluids if she can. Okay.